Chapter 19 Anti-Seizure Medications. Approximately 3.4 million people in the US have active epilepsy, and this is a condition characterized by abnormal electrical discharges from the cerebral neurons, characterized by things like loss of consciousness, involuntary, uncontrolled movements, and these cause a disruption within the electrical brain, secondary to any traumas, anoxia, infections, stroke. And there could also be isolated seizure causes due to things like fever, stress, hypoglycemic reactions, or alcohol and drug withdrawals. EEG, CT, and MRIs are useful tools in diagnosing epilepsy. An EEG records the abnormal electrical discharges of the cerebral cortex. In all seizure cases, 75% are considered to be primary or idiopathic. The remainder are secondary due to external injuries like trauma, brain anoxia, an absence of oxygen, and infections, or other cerebrovascular disorders. And epilepsy is usually a chronic, lifelong disorder. Some common generalized seizure types would include things like a tonic-clonic, formerly known as a grand mal, not a grand mal seizure, a grand mal. Your grandma could have a grand mal seizure, but they are different. There could be absence seizures, formerly known as petit mals. These usually occur in children and result in a brief loss of consciousness for 10 seconds or less. There could also be psychomotor manifestations like repetitive behavior, behavioral changes, and motor seizures. Anti-seizure drugs work in one of three ways: suppress sodium influx, suppress calcium influx, or increase the action of GABA. Used for epileptic seizures, also called anticonvulsants and anti-epileptic drugs, they stabilize nerve cell membranes and suppress abnormal electrical impulses within that cerebral cortex. With anti-seizure drugs, seizures are controlled in approximately 70% of patients. Hydantoins, the first seizure drugs used to treat seizures, was phentoin, a hydantoin discovered in 1938. It works to inhibit sodium influx, stabilize cell membrane, reduce repetitive neuronal firings, and limit seizures. Side effects include things like gingival hyperplasia, nystagmus, ataxia, headache, dizziness, drowsiness, hypotension, insomnia, confusion, depression, paresthesia, purple glove syndrome, suicidal ideations, hyperglycemia, GI distress, and constipation, just to name a few. This category of medication also has a lot of drug interactions, such as increased effects with cimetidine or sulfonamides, or decreased effects with antacids, calcium, and increased effects again with anticoagulants and aspirin. They're contraindicated in pregnancy and have a therapeutic serum level of 10 to 20 micrograms per milliliter. Next would be barbiturates, such as phenobarbital. This works to enhance GABA activity. Used in cases like tonic-clonic seizures, partials, myoclonic seizures, or status epilepticus. It has a therapeutic serum range of 15 to 40, with side effects including sedation and intolerance, and when discontinuing, it should be a gradual discontinuation. Next will be succinimides. These work to decrease calcium influx, such as in the case of absence seizures. They have a therapeutic serum range of 40 to 100, and adverse effects such as blood dyscrasias, systemic lupus, or psychosis and suicidal ideations. Next up would be benzodiazepines, such as clonazepam, to treat absence and myoclonic seizures, though the tolerance may occur after 6 months of use. Other benzodiazepines, such as lorazepam and diazepam, could also be used to treat things like status epilepticus. They're administered IV in the case of status epilepticus, which is a severe seizure followed by seizure one after the other. This drug has short-term effects. Other anti-seizure drugs may be given during or immediately after the administration, as diazepam is usually used for that emergent situation. Next up will be carbamazepine. This would be a drug used to treat tonic-clonic or partial seizures, and is also commonly used for psychiatric disorders such as bipolar. It has a therapeutic serum range of 4 to 12 micrograms per milliliter. Valproic acid, this is one you'll see very commonly given, prescribed for tonic-clonic, absence, and partial seizures. It has a therapeutic range of 50 to 100 micrograms per milliliter, and side effects and adverse reactions including dizziness, drowsiness, weakness, insomnia, diplopia, GI distress, suicidal ideations, or thrombocytopenia. In the case of anti-seizure drugs in pregnancy, 1/3 of females with seizure disorder are at greater risk of pregnancy within pregnancy. Unfortunately, many anti-seizure drugs are also teratogenic or toxic to the fetus. The anti-seizure drugs tend to also inhibit vitamin K, which contributes to infant hemorrhage soon after birth, as well as vitamin K that may be given during the last few days of pregnancy or given to the infant soon after birth. These anti-seizure drugs also increase the loss of folate or folic acid in pregnant patients. In this case, they'll need daily folate supplements. In the case of febrile seizures, or those associated with fever, they commonly occur in children between 3 months and 5 years of age. Epilepsy develops in approximately 2.5% of children who have had one or more febrile seizures. Prophylactic treatment for high-risk patients, especially with phenobarbital or diazepam, is highly encouraged. Status epilepticus, as we said, this is one continuous seizure state, or more accurately, the patient is having successive seizures followed by seizures followed by seizures, and is a medical emergency. We must treat them as quickly as possible. Emergent medications are going to have a rapid effect, things like diazepam, lorazepam, followed by phenytoin IV. For those continued seizures, midazolam or propofol may also be indicated. Using our clinical judgment, especially in a drug like phenytoin with so many adverse effects, we want to obtain a current accurate health history, including drugs and herbs used, and determine any renal and hepatic function lab values. We also want to look at cues like injuries, falls, and the need for patient teaching, while also generating solutions such as the patient's seizure frequency will diminish. Taking action, you want to monitor serum drug levels of anti-seizure drugs to determine that therapeutic range. You also want to carefully warn female patients taking oral contraceptives and anti-seizure drugs to use additional contraceptive methods. This is a ATI and NCLEX question that comes up a lot, as many of these anticonvulsants will also lower the effectiveness of their oral contraceptives. We also want to carefully use seizure precautions for patients at risk of seizures. Safety is going to be a top priority. Also advise patients not to drive or perform any other hazardous activities when they're initiating that drug therapy. And till we're sure what effect these drugs are going to have and how effective they are going to be at limiting their seizures, because we do not want the patient at any risk of having a seizure while driving. For our first practice question, before administering a daily dose of phenytoin, what is most important for the nurse to do? Would that be A, maintain the patient on bed rest, B, check phenytoin levels, C, monitor intake and output, or D, monitor renal function tests? That answer is going to be B, check the phenytoin levels. Practice question 2. A patient was discharged 3 days ago on phenytoin therapy for seizure disorder. The patient comes to the emergency department experiencing seizures. What will be of most value to determine the etiology of the returned seizures? Would that be A, a CT scan, B, an EEG, C, serum phenytoin levels, or D, serum electrolytes? That answer is going to be C, serum phenytoin levels. Practice question 3. When assessing a patient taking phenytoin therapy for seizure disorder, which indicates an adverse reaction to this therapy? Would that be A, thrombocytopenia, B, leukocytosis, C, gingival atrophy, or D, hypoglycemia? And that answer is going to be A, thrombocytopenia. Remember again the effect that these anticonvulsants have on lowering the patient's vitamin K level, and that vitamin K is closely linked to the patient's clotting factors. And for our final question, a patient is experiencing status epilepticus. The nurse anticipates immediate administration of which drug? That be A, phenobarbital, B, phenytoin, C, valproic acid, or D, diazepam? And that answer is going to be D, diazepam. Seizures are a complication you're going to see come up a lot on ATI and NCLEX. Our top priority is always going to be safety. We want to make sure that if that patient's at risk of a seizure, we always have our bed lowered to the ground. Should they have a seizure, we're moving the patient onto their side, so if they vomit, they're not aspirating. Protecting the airway by loosening up the neck of their clothes, making sure we've protected that airway. We've protected that patient from injury. We're then looking at emergent medications like diazepam, and also careful documentation, everything from the characteristics to when it began, how long did it go. What was the onset? What was the duration? But anyway, that's all we got for this chapter. I'll see you in the next slides.